So, good evening, everybody. I picked this topic, as Dr. Ehler rightfully said, mostly because I was very interested in the fever patterns, and I feel like there's not much information out there in terms of, just simple Google search and finding it. I had to really do a lot of digging, and I thank Dr. Green for giving me a wonderful book, which I'll share with you guys later. So we'll talk about fever patterns and infection. We'll talk about different patterns of fevers, and I learned a lot from the lecture, so I'm hoping that you all will learn something and take something out of this lecture and learn something that you haven't read before. So fever, it's one of the oldest clinical indicators of disease. We all see fevers, and especially in our profession, some of our folks are from medicine. We always see fevers. It can give you important diagnostic clue as to if this fever is related to any infection, non-infectious, all that. It is a very essential host defense mechanism. I'm not going to go a lot into the fever, how we all, how the fever is produced in the body and all that, but we all know that, it's an essential host defense mechanism. So break down the fever into three big classes: infection, inflammation, as well as any neoplasm, and malignancy or trauma. So all those, 3-4 different things can give you fevers. So keep that in mind, the triangle: infection, inflammation, and neoplasm. And you can always break down your differentials based on those three. It's not always infection, as Dr. Montero always says. Fever does not always mean infection, but other things can give you fevers as well. Classifications of fever based on duration: you can have acute fever, subacute, and chronic. And the height of the fever, as how high the fever goes, you can divide it into different categories as well. So the acute fever is usually less than 7 days, and viral upper respiratory infections or malaria. Subacute fever, less than 2 weeks, usually intra-abdominal abscesses or typhoid fever, which we don't usually see around here. And chronic or persistent fever, greater than 2 weeks, always keep in mind your TB, HIV, cancers, and connective tissue diseases. That's the CTD. The extremes of temperature: hyperpyrexia, which is greater than 106, and often than not we have encountered these kind of fevers. Hypothermia, less than 97. So keep those temperatures in mind. Hyperpyrexia is greater than 106 and hypothermia less than 97. So when you see such a high fever, keep in mind that it's not usually an infectious cause. Think of something else than infection. And I've heard attendings talk to me about that too, like, during grounds, like greater than 106 does not, typically, it's not an infectious cause for such a high fever. So what are some of the non-infectious causes that you can keep in mind? Central fevers, which we will talk about a little bit in the next slide. Drug fevers, which we see that a lot. Heat stroke, HIV, and the last two are the ones that, a lot of times in internal medicine, or we see that. Malignant hyperthermia, the neuroleptic malignant syndrome. So central fevers, drug fevers, and HIV can present like that too. Hypothermia, usually more often than not, it's the elderly population that presents like that as sepsis. Cold exposure, hypothyroidism. You can have, if you have chronic renal failure and you present with sepsis, you can present with hypothermia rather than having a fever. If there is hypothermia and bacteremia, that equals bad prognosis. So if your patient has bacteremia and they have hypothermia, that's a bad prognosis. So fever, I kind of broke this down into two main components that actually lead to cause fever in human host. Pyrogens are the products that actually cause fever, and they can be broken down into exogenous or endogenous. The exogenous components are usually the LPS from the gram-negative organisms, or the cytokine, especially the microorganisms. That's the outside component that's causing the fever. And endogenous inside the host is the cytokines, our own cytokines that lead to fever. Cryogens make sure that we don't mount a fever that's just not tolerated by our body. And those are the cytokines, the hormones, and the other products that help watch that. So pyrogens and cryogens, those are the two things. So when we establish a cause of fever in a patient, we look at 4 important clues. We can look at their clinical picture, how they presented. The labs help us. How does the patient look? Does he look too good for a fever? Or does he, is he looking like he's looking septic, toxic? The fever pattern and the fever magnitude, like how high the fever goes and what's the pattern. And that's going to be the chunk of our talk. And the abruptness of the onset of fever, how quickly the fever develops. So those are the 4 things you always look for when you're looking for what is causing this fever. So now something about fever patterns. Patterns of fever were used in the past, and they have been used for many centuries to actually tell a clinician what are the possible differentials for this fever pattern. And although it's used in it can be helpful in a handful of infectious diseases, but certain infections, they are so typical for producing a specific pattern that they are just, if you see a pattern like that, that it's this infection. It could be this infection. So certain infections definitely give you a specific pattern, and that can help you come up with a diagnosis, or at least come up with a working diagnosis. And it has been questioned by a lot of experts that okay, it doesn't really help you, but they have been described and they have been helpful. If especially in the scenario where where fever is the only thing that a patient presents with, there's no localizing signs, and the pattern of the fever itself can tell you, okay, well, maybe these are the differentials, this is what could be causing this particular fever. So when patient does not present with a localizing sign, a fever pattern may be the only way to help you. So it's always good to know that. And a lot of the infections like mononucleosis or roseola in kids, miliary TB, all those can have a specific pattern, and it can help you, and they usually present with very non-specific symptoms, but the pattern itself can help you jump to a diagnosis. So not clearly understood why specific infections have certain fever patterns, but it has been described, but it's not completely understood still. And fever takes a characteristic course in a lot of diseases. It can be, we will talk about the patterns, and you'll see that certain diseases are related to certain patterns. So new infectious diseases have emerged, and the fever patterns are changing according to that. So what mechanisms underlie the fever patterns? It's not entirely understood, as we talked about. Some diseases, like malaria, you can see that the fever pattern is based on the life cycle of this particular, organism that causes malaria. So with P. vivax, Plasmodium vivax, and ovale, those two give you tertian fever. What is tertian fever? Tertiary every 3. So what happens is that the parasites are released into the bloodstream, and those can actually activate the pyrogenic cytokines, and that causes the fever. So there's cycles of fever that happens every 3 days, and we'll see the graph in the next picture. Malariae, cordon fever, every 4 days. So the fever is every 4 days. Falciparum, on the other hand, is quotidian fever. I don't even know how to pronounce that, but we'll try. Quotidian fever, and that actually gives you daily fevers with spikes, and it's every day the fever. There's no like every 3 days, every 4 days. The other one, the Knowlesiae, is the one that gives you this fever like falciparum as well. So when you see this graph, you'll see that falciparum, as you can see, is there a pointer? No. Okay. You can see that it has a spike every day. On the top, you'll see the number of days, and then you can see that it has a spike pretty much every day. There's a spike, then it comes down, then there's a spike again on the next day. The vivax, you can see there's a spike on the day 1, then there's a spike on day 3, then there's a spike day 5. So like every 3rd day there is a spike. Same with the ovale. And malariae every 4th day. So just remember this pattern. The fever patterns, there's 3 major patterns based on the frequency of the fevers. There is a sustained or continuous fever, there is an intermittent fever, and there's a remittent fever. And honestly, I never heard of those. But preparing this talk made me understand a lot of these different kinds of fevers that are existent. So we'll talk the major patterns, we'll talk about those, and then we'll also talk about other fever patterns which are very interesting. There's a single spike fever, and what should you think about it? Like just one fever. PEL-EBSTEIN fever. There's low-grade fever, hectic or septic fever, stepladder fever, biphasic, relapsing, double quotidian, and inverse fever. So those are the different kinds of patterns that are associated with specific diseases. And there's always an overlap, like brucellosis can have different kind of fever, but the hallmark fever with brucellosis is called undulant fever, and we'll see what that is as well. So this one, and so the dotted lines, consider that as the normal temperature, and you see from day to day there's a pattern. Can somebody guess what kind of major pattern that could be? There's a spike every day, alright, and the temperature is above normal every day. So the patient started out here on day 1 like a low grade, went up, and then he's always stayed in this range. What could that be? Yep, sustained fever, correct? So that's a sustained or continuous fever. So they start out low grade, and then they live at this high temperature throughout the duration of the illness, and they don't come back to normal. So daily elevated temperatures over 100.4. The fluctuation of temperature, like from day to day, is less than half Fahrenheit. So pretty much stays stable, except that there's minor difference from day to day, less than 0.5 Fahrenheit, and in a 24-hour period. So if you can see in this graph, there's basically very little difference from this spike to this spike. Pretty much it stays around the same kind of level. So remember this, the temperature remains above normal throughout the day. It does not come back to normal at any time. So the common diseases associated with this kind of pattern, central fevers, drug fevers. If a patient presents like this, and actually personally I've seen that with drug fevers, often than not at Moffitt. There's roseola, which is the kids have it, and febrile seizures, lobar and gram-negative pneumonia, rickettsial disease, acute meningitis with bacterial meningitis, and then also the nosocomial infections with IV catheters or CSF shunts. So keep these in mind with sustained or continuous fever. Anytime you see such a pattern, barring the fact that the patient may have been given antipyretics to bring the fever down, but in general these diseases are associated with sustained or continuous fever. And that's why these patterns are not necessarily all the time useful in hospitalized patients, but they do tell you that this is what's going on. Central fevers, a little bit about them. Anterior hypothalamus in our brain, it actually initiates the signal to sweat in response to the fever. The posterior hypothalamus, it establishes the set point of your body temperature. And when you damage the hypothalamus for one reason or another, there is loss of control of body temperature regulation, and so there is fever, like over 106, like we saw before. And generally there is no response to antipyretics. So keep that in mind. You give Tylenol or anything, they're not going to respond to this. They're just going to have these high fevers, sustained fever pattern. Drug fevers are usually low grade or high grade. They can be both. The patient looks inappropriately well for the degree of fever. They have a fever of 102, 103, and they look great. They don't even look like they're having a fever. They can have relative bradycardia with temperature over 102. And what's that sign called? The relative bradycardia with a high, Fajay's sign. They usually don't have cutaneous manifestations, but we do see them from time to time. The drugs most commonly associated with drug fevers, beta-lactams, notorious for that, and quinidine, alpha-methyldopa, procainamide, and INH. They all can cause drug fevers, but realistically, pretty much any drug can cause drug fever, but they are very common. So this is a great picture that I had to actually take a photo of from a book because I just couldn't find great pictures. And so here you can see from these are the day numbers, and this is the temperature in Fahrenheit, of course. You can see that the patient has started out with a low grade, went up, and then they have been kind of living around this temperature, if you can see. So again, this is a sustained or continuous fever pattern. The constant body temperature above 100.4 is a sustained fever. True or false? Right. True, correct? Great. Sorry. Alright. So we'll talk a little bit about pulse temperature dissociation. Fever with relative tachycardia, usually seen in toxin-mediated infections. So they have fever, but they have unproportionate tachycardia. There's so much tachycardia that it just doesn't correlate with the amount of fever, and that's usually seen in gas gangrene, or it could be a non-infectious cause as well. The fever and relative bradycardia, we talked about it. It's called the Fajay's sign, and the diseases associated with that particular Fajay's sign is untreated typhoid fever. You can get them with brucellosis, yellow fever, psittacosis, and leishmaniasis. So Fajay's sign, remember that. In a hospitalized patient, two things to remember for Fajay's sign: Legionella, Legionnaire's disease, and drug fevers. Those are the two things you should keep in mind when you see something, a pulse, a fever, but they have, the heart rate does not, climb up as much as they should, because you should have tachycardia with fevers, but it doesn't happen. So this graph can kind of do the justice. So this is the fever that the patient is, let's say this fever spike, their heart rate is like kind of like low, like it's not as high as it should be. So you can see with lower fever, their heart rate, with this fever spike, their heart rate is not as elevated. You can see that with this graph. So fever spikes, there's another question, fever spikes interspersed with normal temperatures, but then the temperature returns to normal at least once in 24 hours. What do you guys think this fever pattern could be? Great. So intermittent fever, and we'll do a little bit of graph in this pattern. So they have a fever spike day one. They have a fever spike, but then on the same day it comes back to normal. Then they have a fever spike again, comes back to normal. So like they keep having a fever, but then it always comes back to normal within the 24 hours. Now this is called intermittent fever, also called periodic fever. There's wide fluctuations of temperature. You can see here, like, it's all over the place, the temperature spikes. The fever is present only for several hours, as you can see in the graph as well, during a particular day. So in a day, the fevers is only present for several hours. They have greater than 100.4 when they have a fever. Usually there's normal temperature in the morning, but then it peaks in the afternoon or evening. And the main thing to remember about this one is that it returns to baseline, and it comes back to normal each day, at least once during most days. So as you can see, they start out in the morning time, like probably here, day one, they start out normal, then it peaks around afternoon, evening, comes back down to normal. So that's how, and then it keeps happening every day. They come back to normal, then go back up the next day. Now, what diseases are associated with this particular fever are the biogenic infections, deep infections, abscesses. Endocarditis has been associated with this kind of fever. TB, schistosomiasis, and Kala-Azar, the visceral leishmaniasis. So these are the common things, but the key was to remember the pyogenic infections, abscesses. They can present like an intermittent fever. Something about fevers in malaria, what happens, the hemolysis of the red blood cells by these malaria species cause the fever spikes. So the fever spikes occur when there is lysis of the RBCs in a pattern. So if it happens every 3 days, it's particular species. If every 4 days, it's particular species. And these are also called the intermittent fevers. And as we spoke before, every 24 hours, falciparum and non-lesiae. Every 2 days or so is ovale and vivax. And I'm sorry, every 3 days is tertian. Every 4 days is cordon. There's a typo in this one. So you can see here the graph, which tells you that there's like a spike each day with falciparum. Each day you'll see a spike. With vivax and ovale every 3rd day, and then malaria every 4th day. So fever spikes, there's a next question. The fever spikes and falls without a return to normal temperature. So you have a fever spike, it comes back to normal. Well, it comes back sort of close to normal, but never to normal. Which kind of pattern do you think it is? Remittent, right? So we'll see the graph. So remittent fevers, you can see here on day one they start out with they climb up with the fever, and the normal, let's say, is around here. So they start out normal here, and then they spike. They come back sort of close to normal, but not normal, and then they spike again, come back to close to normal. So that's the remittent fever. So fever with daily fluctuations exceeding about 2 degrees. There's wide swings in temperature like the intermittent fever, and temperature remains above normal. So whereas in the intermittent fever they come back to normal, the remittent, they don't return to normal, and it does not touch normal at any time. The common diseases, a lot of viral infections are associated with this particular pattern. Infective endocarditis with lower grade pathogens, rickettsial infection, again, brucellosis, Legionella mycoplasma, and acute rheumatic fever that can present like a remittent fever. Another graph to sort of go over this, so you can see that that's kind of like the normal, let's say the temperature that the patient starts out, spikes, comes back down, but it's not nearly close to normal. And you can see that they usually just stay above normal when the temperature falls. Undulant fever, it's also called Malta fever. and some sites suggest a Mediterranean fever. So these are the remittent fevers associated with headache, and they're very classic for brucellosis. It's called undulant fever in brucellosis. It's a remittent kind of fever, and they have headaches. So you can see that the difference between remittent and intermittent, let's say the red line is the normal there. They have a fever, and this is the normal here, 98.6. They spike a fever, but they never come back to normal with remittent, you can see. Whereas with intermittent, they come back to normal around here. So that's the difference between intermittent and remittent. So this is in general all the three kind of major fevers that we talked about. Sustained, you can see, just climbs up and then it just keeps at the same kind of level. Intermittent comes back to normal, and remittent does not come back to this dotted line. It just stays up and down, up and down, up and down. Now we'll talk about relapsing fevers in the next few slides. The single spike fever, when you see just one spike of fever in your patients, think about a blood product transfusion, or maybe it's a temperature error. Take it again. There could be a contaminated infusate that they're getting, and manipulation of a mucosal surface, or things like that. So if you see a single spike, think about these things. We'll do a quick case. A healthy 31-year-old dentist. He has cough, myalgia, and lassitude, and then he has a fever up to 103.2, associated with rigors and night sweats. The exam, the urinalysis, blood cultures, everything came back unremarkable. After about 14 days, the fever went away, and her symptoms went away as well. Then this afebrile period lasted for 7 days. Then the fevers came back up, 102.3, associated with rigors and sweats. Then again another 5 days afebrile, then again 100.9 with lesser symptoms. So overall, this patient recovered from this up and down of fevers over 5 months. So kind of, what do you guys think this fever pattern is? So yeah, but I was trying to get at PEL-EBSTEIN fever. What is that? It's also called Epstein. It's based on the names of these two, physicians who found this type of pattern, and particularly in lymphoma patients, in Hodgkin's lymphoma patients. It's daily high-grade fevers for about a week. Then they have low-grade fever for next week, and then so on. So they keep having this pattern where they have about 3 to 10 days of fever, high-grade fever. Then they become afebrile, and then they have the same pattern again. It's very typical for Hodgkin's lymphoma, but it's also rare when you see a Hodgkin's lymphoma patient. But anytime you see such pattern, you should think about three major things: Hodgkin's lymphoma, acute CMV in an immunocompetent patient, not an immunocompromised, and also think about primary progressive TB in HIV population. So those three things, based on like the kind of fever pattern this is. The cause of this kind of pattern with febrile, febrile is the cyclical release of cytokines, and in lymphoma patients they have necrosis of their lymph nodes with damaged stromal cells, which releases cytokines, and then they have fevers periodically. The treatment is NSAIDs. Low grade, they have daily evening fevers for several days. It's usually around 100.4, and it does not really indicate disease, but TB patients can have that. The other associated causes are exercise, hot weather, warm foods, and vaccine. If they got a DTP vaccine in 24 hours, they can have a low-grade fever. Hectic or septic fever or high spiking fever, they have daily temperatures greater than 100.4. There's a wide swing between highs and lows, and this could be either a remittent pattern or intermittent. Remittent where it does not return to normal, and intermittent where it comes back to normal. So it couldn't be either or pattern. It's suggestive of a bacteremia. there's occult deep tissue abscess, peritonitis, and dental abscess, EBV, and endocarditis, Kala-Azar. Still's disease as well. So think about Still's disease if you see like such high spiking fevers, and daily they have temperatures. Stepladder fever is the fever that usually is seen in typhoid fever, and is very classic for it, that they have temperature rise and it goes up, and then there is a higher level with every spike. So they would start out with 100.4, then go to 101, then 102, then 103. Like they have a ladder kind of pattern. And the new plateau is higher than the preceding one. It's very classic for typhoid fever. And you can see it in this next graph. So they start out and they keep climbing up. They keep climbing up. They don't just stay in one kind of temperature range. They just develop like higher and higher and higher fevers. And once they have appropriate therapy, it just gradually comes down in a step ladder fashion as well. So very classic for typhoid fevers. 23-year-old male from Ethiopia. He presents with jaundice, malaise, and he has purpuric lesions on abdomen. Several days later, he has this pattern. And if you guys can see the days, so he starts out having fevers for about 5 days, becomes afebrile, and then has fevers again. Afebrile, fevers again. So, and then you see this, these squiggly lines in his peripheral blood smear. What do you guys think? What kind of fever is this? So, relapsing fevers. So fevers, and that squiggly lines, they were Borrelia recurrentis. Fevers relapse every 4 to 14 days, and it repeats the same cycle. So they have fevers in the same kind of range. They become afebrile, and then they spike fever again. So it keeps relapsing. The relapsing fever can have infectious as well as non-infectious causes. And the febrile episodes are separated by normal temperature. So like they will have fever for like 4 to 14 days, then afebrile for a period of time, then again fever trend. And interestingly, the most temperature elevations are at night in this particular pattern. The fever can last anywhere from 4 to 14 days, and then temperature gets normal. Borrelia infections, Borrelia recurrentis, the relapsing fever, you can see that they have like fevers for a certain amount of days, and then they become afebrile. Fevers again, afebrile. So infections often involves multiple Borrelia subtypes. As one serotype is cleared, another one proliferates, and that's why you get this relapsed kind of picture. These serotypes of each particular Borrelia, they keep alternating, so you keep getting fevers. B. recurrentis usually is with a louse, an African epidemic relapsing fever, and it's just a single relapse usually. With Hermsii, which we see in US, which is transmitted through a tick, it can have as many as 12 relapses during the course of the illness. And there's other Borrelias existing as well. But relapsing fever, classic Borrelia infections. Biphasic fever, it's called camelback or saddleback. And there's 2 fever spikes during the illness. So during, like if there's a 7-day illness, they'll have just 2 fever spikes, and that's called biphasic. There's constant fever for 1 to 2 days, then they become afebrile, then there's a relapse of fever, but only twice. And the diseases associated is usually dengue fevers, and the yellow fever, Colorado tick fever, rat bite fever, all these fevers. But dengue fever, biphasic fever, just remember that way. So this is how the camelback fever looks like. They have this pattern. They have like this kind of fever spike here, and then they become afebrile during this illness, and then they again spike. So they have like 2 fever spikes during the course of the illness. That's the biphasic. And these are the different types of relapsing fever, because every time the fever is coming back. The tertian fever we discussed with malaria, cordon, biphasic, and then the there's this entity called double quotidian fever, which we'll talk about quick. 2 spikes of fever every day, and the graph will do the justice to this. They have 2 spikes every single day. There's one in morning and one in evening. That's why it's called a double fever. In just the single quotidian fever with P. falciparum, there was just 1 spike every day. Diseases associated with this, it's adult still disease can present like this, so keep that in mind when you're seeing a patient with such kind of pattern. And then of course the malarial infections, miliary TB as well. So you can see here, each day there's like 2 spikes. You can see 2 spikes, so double spike every single day. That's double quotidian fever. Inverse fever, the temperature usually rises in early morning rather than in evening. The normal pattern, the diurnal pattern of fevers is that you should have fevers at night. This one is just an inverse fever. It presents like it's high in the morning hours and then it just comes down in the evening. So miliary TB, not military TB, and liver abscesses, they are associated with such kind of inverse pattern. Recurrent fevers, you can have like usually why they keep having fevers is you can have cyclic neutropenic fevers, and cancers, you have tissue necrosis, then there's intermittent release of the cytokines and you get fevers. Relapsing fevers, as we said, the spirochetes are released into the bloodstream and you get fevers. And once the spirochetes cleared from your circulation, the fevers go away. So that's why you keep getting those kind of relapsing pictures. The fevers from cancers, how do you differentiate them from infectious causes? You can do a quick naproxen test. And naproxen test, what you do is that give the patient naproxen and give them for 3 days. So if they have fevers due to cancers, they will come down rapidly. But if there will be no change in fevers if it's due to an infection. So that's a quick test that you can do. It's not really useful to differentiate the non-infectious fevers from from cancer fevers or connective tissue disease fevers. And I just thought I'll quickly talk about this. We're pretty much at the end of our talk. Assam fever, there is actually a state in eastern India. It was epidemic in 1880s, and this is also the Kala Azar, and Kala means black in Hindi, and that's why it's called Kala Azar, because they have a characteristic darkened skin. So that's why it's also called Assam fever. I did not know about that. Black water fever, it's from the malaria, because you have hemolysis and then you get the passage of, it's a dark red or a black urine, so it's called black water fever. Bullous fever is Emballoma americanum, the tick bites that cause this fever. It was actually first observed in soldiers in Bullis, Texas, in Camp Bullis. So that's why it's called Bullis fever syndrome. Central fever, we know. Cotton fever was really interesting. It's associated with IV drug use. Cotton, if cotton is used to filter the heroin or these other drugs, the endotoxin from this bacteria, which colonizes the cotton plants, is the one that causes the fever. So it's called cotton fever. Canicola fever, the name Canicola, vector dog, canine, Canicola, Leptospira interrogans, and it's transmitted by the infected urine of dogs usually. So it's called Canicola fever. Haverhill rat bite fever, the strep moniliformis, and it was first described in Haverhill, Massachusetts, back in 1926. So it's called Haverhill fever. Izumi fever is also called it's also the synonym for pseudotuberculosis by Yersinia pseudotuberculosis, and it was first described in Japan. So it's called Izumi. It was in a town called Izumi. This was interesting. Jacquard's dissociated fever, the TB meningitis. When the patient has TB meningitis, they can present with a paradoxical slow and an irregular heart rate, and that's why it's called dissociated fever, and the Jakuts is the guy who actually, the physician who described this. Katayama fever, we know, we've heard of this. It's a town in Japan where the disease is actually endemic, and it's the acute schistosomiasis. That's why it's called Katayama fever. Parrot fever, psittacosis. Q fever, this was very interesting because I never knew why it's called Q fever. The Q stands for query, and it was used because back in the days when they described this fever, they just didn't know what caused this. So Q fever, Q stands for query, and it's Coxiella burnetii, we all know. Rabbit fever, tularemia, makes sense. Actually, it's called tularemia because of this disease actually killed a large number of ground squirrels in Tulare Lake in California back in 1911. So that's why it's called tularemia. Spotted fevers, it's a misnomer. We know that it's not just in Rocky Mountain, it's in other parts of US as well. And undulant fever is the wave-like or undulant nature of fevers with brucellosis. It's called Malta, is a town, I forget where it was, but it's called. West Nile fever, it was first isolated from a 37-year-old female in West Nile district of Uganda in 1937 during research on yellow fever virus, so it's called West Nile fever. And I had this nice fevers less than 102. You can have all these causes. Over 102, you should think about cholangitis, pericarditis, and other pyelonephritis. So just very quick, fever defervescence. If you have a viral illness, you have a slow temperature defervescence, usually over a week. If it's a non-infectious disease, they usually don't come down without a specific therapy. And bacterial infections, you see a prompt drop in their temperature with treatment, with appropriate treatment. The reappearance of fever during a treatment, you treat, let's say, a bacterial treatment and a bacterial cause of an infection, and you're like, okay, well, the fever is not coming down, it comes back up. It's not because of resistant organisms. You can have infectious complications. Either the patient has drug fever or septic emboli in endocarditis. And something to keep in mind, immunocompromised hosts, they respond more slowly to antibiotic therapy. So their fever curve comes down slowly compared to the immunocompetent patients. And special thanks to Dr. Green for letting me borrow this book, which had great review on fevers, and it's a great book for, it was in March 1996 that it was written by Dr. Burke Kuna. And thank you.